first responder bag. To start off with, I'm going to check the front pocket, which has diagnostics equipment in it. So inside there should be a stethoscope, a pediatric BVM and an adult BVM. There should also be a thermometer, and there are. And then it would also be a blood glucose level measurer, which usually has the PPE, protective gear kit in it. So I check for plastic bags, face masks, eye protection, all of that will be found in there. I'm going to open up the bag. So in the top pocket I have medication, so in here you'd usually find paracetamol or ibuprofen, as well as methoxyfluoride. So what I'd do is I'd check the expiration dates on all of them, and if any had expired or I'd run out, I'd replace them. Next we have the airway adjuncts pocket, so in here I would find OPAs and MPAs, airways. Down here we have airway medication, so in here that would usually be adrenaline or anything that you might need to combat asthma, and then we also have some stuff to help with the airways like nasal prongs or nebulizers. As we get into the big pocket we have the sharps disposal, we have a towel, we have a bag of IV fluid or sodium chloride, here we have the sharps roll, and then we have an adult BVM, which I would check if all the parts were there, which will be in my BVM section, and a pediatric BVM. Then we have the LMAs here, a slippery sand, some cardboard for splints, a neck brace, and then here we have the hemorrhage package. So in here you would find whatever you need for bleeding, cat tourniquets, bandages, gauzes, and a whole lot of saline water, and I would check that I have enough in there. And then over on the other side we have another PPE pocket, which is this one down here. So in here you'd usually find emesis bags, you have some masks, and then over here we have the hypoglycemia management pocket. So in here we've got glucogen, glucagon, and glucose, as well as this syringe to identify an oxygen bottle. So the newer ones are all white, but some old ones might have a black strip. The big giveaway is they usually have oxygen written on them, or otherwise you'll find. So what you want to do to check if you've got oxygen is you'll open up the master valve, turn it on, and if there's enough oxygen, this arrow will come up towards the green. If there's not, what you'll want to do is change the receptor onto a new bottle. So how you go about that is you depressurize the receptor, which is closing the master valve, opening that up to all the air leaves, pointing away from your face, and then taking that off. Now when you're swapping over, you want to make sure that you have the Bodoc ring in there, which is this little, can't really see it on the camera, but this little circle here, and then you put it back on, line it up, tighten it up, like that. Okay, so the main indicators to use oxygen is if the SpO2 has less than 94%, if they have an airway obstruction, if they have brain trauma, if they've gone into shock, if they suffer from decompression illness, or if they've recently been sedated. But the main way to tell is if your clinical judgment tells you that they need. What a high-risk patient usually is would be someone with cord, someone who's on their own oxygen, or someone who is morbidly obese, for example. What I'm going to demonstrate today is how to put nasal prongs on, so you'll want to lie the bottle next to you so it doesn't fall over. Nasal prongs are usually used for people who need a very low amount of oxygen, and you would release it at 2 to 4 litres per minute, and you put it on by putting the nasal parts in, tucking behind the ears and tightening under the chin. The different compartments are on the end here. We have the catheter that goes in the patient's mouth, we have the tubing, and then we have the container. If you want to test your suction device, and how you would do it with this particular model, you hold test down, turn it on full, let it go, cut off part of it, and then you'd wait for the lights at the top to reach the top. So So they haven't here, so you'd report that, and then once suction stops, you let it go and turn it off, and that's how. It would be appropriate to use the suction device. You always have to be prepared to use it if your patient has a low GCS or they are immobilized. Another time that you would definitely use suction is if there is fluid or foreign matter in the patient's mouth and they're unable to clear it by themselves for one reason or another. However, most of the fluid should be removed with a roll if possible, and you should never use this if the patient is choking, because you don't want to send the catheter further down the throat than the oropharynx, which is where you can see in the mouth. Now, if we were to appropriately use suction on a patient, we would turn them laterally on their side. We would get the catheter, put it in their mouth, only as far as you can see, turn suction on, and suction everything out on the way out. And you would suction for no more than 10 seconds. Now, when you're suctioning, you have to bear in mind that some complications are associated with it. The main ones are inducing emesis or vomiting, brachycardia from stimulating the nerves at the back of the throat, hypoxia from suctioning around the lungs, soft tissue trauma. Indications of BVM use include bradyapnea below 12 breaths per minute, poor perfusion of oxygen in the body, and stuff like drowning where the patient isn't able to breathe by themselves. Potential complications of BVM use are hyperventilation of the lungs, gastric inflation, and barotrauma. Indicators of difficulty with a BVM, we follow the MOANS acronym. So M stands for mask seal, if there's anything in the way of the mask seal over the nose and mouth. Obesity or obstructions, so if they're too fat or they have something like a beard or piercings around their mouth. Age, so if their skin's too thin. No teeth or neck mobility, if the patient is stiff or if they snore. Okay, so the parts of the BVM are the BVM chamber, the reservoir. You would make sure you have 2 masks of different sizes, the filter, the PEEP, and the O2 tubing. What the PEEP is used for is it stands for positive end expiratory pressure. So you would use it to stop air leaving the lungs and to splint the lungs open to make more area for gas exchange within. You use it on almost every patient except ones with cardiac arrest because it messes with blood pressure and takes up a lot of space, and things like pneumothorax or cord. When you want to check the BVM, first you'll inflate up the chamber, so you cover it, and there shouldn't be any holes. Then you inflate the reservoir to check that there aren't any holes in that. Doesn't seem to be. You attach that. You attach the PEEP, the filter, the mask, and the oxygen tubing. BVM. There are 2 ways to hold it. There is either single grip, which is when you're by yourself, where you do a C grip round and you pump like so, or there's double grip, where the BVM will be pumped by someone else and you hold it like so on the patient's face. The rules of 3 when pumping with a BVM are 1/3 of the bag with 3 fingers every 3 seconds, and the ventilation rates differ for cardiac arrest and non-cardiac arrest. For cardiac arrest you do 8 to 10 breaths per minute, and cardiac arrest you do 10 to 12 breaths per minute. Airway management, you do it whenever the patient has a lower GCS below 8, or whenever they've lost their intrinsic protective mechanisms like coughing, gagging, vomiting. Positions you would do would be the head tilt chin lift. With this one, you put your hands like that and you just tilt the head backwards. This takes the tongue off the back of the throat and is good if the patient has spinal trauma. The next one we can do is sniffing position, which is where you take a towel, or anything really, and you lift the patient's head up so that their ear is in line with their sternal notch. With this it's good because then you have both hands free and it enables for tubing if you have an intensive care paramedic nearby. Another one that you would do if you fear the patient has spinal or neck trauma is jaw thrusts. So you'll put the palms of your hands on their cheeks, grab onto the angle of the mandible and pull the jaw forward. And this allows for the tongue to come off without the neck being interfered with. The last position you would do is recovery position. This is for a patient that has a lower GCS but is able to clear obstructions by themselves and breathe. And it mainly just assists with clearing the airway. So what you would do is you would take the arm closest to you, stretch it out, take the other one and bring it over, bend the knee up, and then turn the patient over towards you. Demonstrate how to put an NPA into a patient. An indicator to use an NPA is if they have a low GCS, lower than 8, and you can't put an OPA into their mouth. What you want to do is check you've got the correct size, so you'll line the NPA up next to their nostril and down the side like that, so that's a good fit. You don't want it too long because it will go too far, and you don't want it too short because it won't do anything. The contraindication of using an NPA is if they've got base skull trauma, because it might pop out the other end. So putting it in, you want to lubricate the NPA up like that, and then you're going to go down perpendicular, not up. If you meet resistance, you spin it until in like so. Complications that come from using the NPAs can be nose bleeding, discomfort, or polyps in the nose. Another airway adjunct you might want to use is the OPA. The OPA is also used for low GCS, and it goes in the mouth like so. You start putting it upside down in the patient's mouth, and then once it's in, you rotate and leave it in like that. Indications for an OPA are similar. If the patient needs help breathing, or if you need to keep the airways open and the patient is unable to do that themselves. Contraindications of using an OPA would be facial trauma, or if the patient still has an intact gag reflex, and complications associated with the OPA. Damage to the mouth if the OPA is too big or too small. It may induce vomiting. We have the life pack that we'll be using on the road, and these are the different parts that it's found in different pockets. We've got defib pads in here. We've got our 12 lead and our shock box and our cardiac medicine in here, so that would be aspirin and GTN and a razor. On this side we have our 3 lead and our SpO2, and when we turn it round we've got our end tidal CO2 and spread printer paper, all 3 of the blood pressure cuffs. Underneath the blood pressure cuffs you'll find the batteries, and to check if the batteries are charged you just press a button and it'll have air, and if you want to take them out you just press there and it comes out, and to put it back in you just slide it in and click. Bottom here we have the printer, and to check that we've got. The important thing to know with the life pack is how to switch it to AED mode and how to print. So the lucky thing about the life pack is when it turns on it automatically goes to AED mode.
Push analyze.
And if you want to print off the vitals, which if you were attached to a patient would be on the screen, all you have to do is press print and then press print again to stop it, and then you would have a printed copy of the vital. 3 lead will be found in here, and it attaches in there, and as you can see on the back it has corresponding letters to where they go. So but generally the leads line up here, 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 and sometimes there. With SpO2 you would just slip that on the patient's finger like so, and it is plugged in up here, and both of those will come up on the screen. What I'm going to show you first is how to change leads. So you would select that one, and then it has lead here. There's only one at the moment, but in theory you click and then choose to change. To change the size of the heart rate, you go down to size, you select, and then you can take it smaller. Play the volume of the heartbeat, you select the heart rate up there, you select, and then you scroll up like that. We'll take it back down and go home. So what you're going to want to do is start by turning it on. You're going to switch it to manual mode, like that. I'm going to take the energy down to 50 joules, like that. And then we're quickly going to do a user test. So we're going to go down to user test, and that's just doing it now. Going to press charge. Going to press shock. And it's delivered. If you want to dump a shock, you press charge. And once it gets to the top, you just press the select button.